Good morning, one and all. I am Dr. SHROFF, and I am going to present my research paper on a study to understand the effect of pupillary dilatation on optical biometry and IOL power calculation. As we all know, the cataracts. The slide is not going.
Can we have some AV support and the timer as well?
As we all know that the cataract surgery is no longer just a vision restoring procedure but a refractive surgery, and unaided 6/6 vision is a necessity nowadays and not an exception. And in such scenario, accurate IOL power calculation becomes very important. As we can see, the pupillary dilatation can affect the final IOL power calculation in various ways, like alteration in the effective lens position, ACD measurements, fixation issues, keratometry variables, etc. As we all know, SRQ formula used to consider the A constant of IOL, power of cornea and axial length of the eye, whereas Barrett formula also includes anterior chamber depth, lens thickness and wide to wide corneal diameter in addition to axial length and keratometry. This is the review of literature. Few papers have suggested that there is no clinically significant effect of pupillary dilatation on IOL master measurements, axial length, corneal power or IOL power calculation by SRKT formula, but Haig's formula is a little more susceptible. Another study by Catherine et al. Suggested that dilating pupil did not adversely affect the IOL power calculation, whereas a study by Teshigawara et al. Suggested that Barrett formula was significantly affected in terms of ACD lens thickness and wide to wide. Another study by Noah suggested that there might be myopic surprise with pupillary dilatation, and another few studies suggested that it was insignificant. So this is my study. We selected 156 cases of cataract surgery, and we compared the IOL power measurements, axial length, keratometry values, anterior chamber depth before and after pupillary dilatation in the same patient. Inclusion criteria included more than 18 years of age, senile cataract, complete IOL power measurements available, both dilated and undilated states, and uneven full cataract surgery. Exclusion criteria was axial length less than 20 mm or more than 24 mm, ocular pathologies such as glaucoma, retinal detachment, dense cataracts, etc. Measurements were done for axial length, anterior chamber depth, K1, K2 IOL power, both before and after pupillary dilatation in the same patient using IOL Master 500. These are the results. The mean ACD and mean AL were significantly changed after dilatation, but there was no significant changes in mean K1, K2 or axial length pre and post dilatation, and mean IOL power calculations were not affected statistically significantly using both SRKT as well as Barrett-Toric formula. However, if we look at the individual readings, we can see that the SRKT formula 67 readings remain unchanged, whereas Barrett formula spherical power only 46% readings remain unchanged, and 31% were having a positive change and 23% had a negative change. Similarly, for cylindrical power calculations using Barrett formula also, only 48% readings remained unchanged. Means more than 50% readings were getting changed either positively or negatively post dilatation. However, we could not study in details the effects. Our findings that AL and ACD were significantly changed, aligned with the previous studies by Huang et al., Teshigawara et al. But there was no significant change in K1, K2 or mean IOL power using SRKT or Barrett formula. However, 50% readings got changed, as I already mentioned. So individual IOL power readings are being affected even though we are not seeing any change in the mean values. Dilatation may introduce variability necessitating caution in biometry interpretation. Residual refractive error analysis suggests no significant impact on final outcomes. And here are the future considerations that ACD, AL, corneal curvature, effective lens position all influence the IL power. So further study is required. So prospective multicentric cohort study might be a better option to go for. So here is the conclusion. Pupillary dilatation significantly affects ACD and AL but does not affect keratometry or mean IOL power calculation. However, 50% of the individual IOL power readings are being changed, especially Barrett formula is more susceptible as compared to SRKT formula. Performing biometry without dilatation may simplify the pre-operative assessment, and further prospective multi-center trial is required. Here are the limitations of my study. It was a retrospective design and sample size was small, and there was variability in individual pupil dilatation. Here I am in references. Thank you.
Hi, nice paper. So I just wanted to ask you one question. Since you said that with dilatation, the axial length and the ACD increases, and of course it's intuitive as well, and you showed in the study that the keratometry remains the same. Could you explain then why the IOL power is not changing significantly, why it's not statistically significant, since the change in axial length and ACD is statistically significant?
Yes, ma'am. So the change is basically either in the positive side or the negative side, and the overall effect is being neutralized in the formula. Maybe the formula are robust because they have such a large database with them. So probably the final IOL power calculation is not much affected despite the mean axial length and mean ACD being.
So I thought both were increased, right? I don't think there was an increase and decrease, but both were increased. Probably one of the reasons could also be because we have a smaller sample size. That's the reason why I couldn't see a significant change, because as if I remember correctly, you said that both are significantly increased. It's not just variability, but both are increased, right? So that doesn't translate into why there is not a significant change in the end. Thank you.
Thank you.
Thank you, Dr. Dr. Uma, wonderful. And it's very important take-home message that once we are detecting case of cataract and pupils are dilated, the biometry should be done when the pupils are undilated to get the most accurate